Fantastic. I think we should start. I'm delighted to welcome you to this afternoon's FNUU session. And we're going to look at the session on new devices and new technologies. And we're going to start with new devices and new technologies for OAB. And that's going to be given to us by Professor Howard Goldman, who's on the faculty of the Cleveland Clinic Lerner College of Medicine and has a big role at the Institute as a Vice Chairman for Quality at the Glickman Neurological Institute. He's got a massive CV, he's very clever, and we're very happy to have him. Thank you.
So thank you very much for having me. It's a pleasure. I had a good time, I was telling them before, yesterday, going to see some football with the English fans. So I guess I picked the right date to come and to really experience it in the United States. I'm not sure they even played it on the regular TV, but so here we got to experience, I guess, how it's supposed to be done. Anyhow, so I think what we'll do for the next 25 minutes or so is talk a little bit about what's happening as far as OEB and what are some things coming down the pipeline that we can expect to see. And let's go right to it. So these are my disclosures. Some of the companies and some of the devices we're going to talk about, I am a consultant for, and I will tell you that you'll see some of the slides are actually slides that I had to kind of pull from companies because otherwise we don't have any good images or things like that. So I'll just tell you that up front. So what's the current state of overactive bladder treatment? And I think right now we would all agree that first-line therapy is behavioral treatment, pelvic floor exercises, things of that nature. Then if patients don't respond to that, we go on to medication. And then if patients don't respond to that or have untoward side effects, we then go on to some sort of neuromodulation, whether it's electrical or whether it's some sort of chemical neuromodulation. So this is the AUA OAB, non-neurogenic OAB algorithm, starting with a history and physical, going on to behavioral treatments, which are standard, moving on to pharmacologic management, and then if things we're still not getting the result we want, we go on in carefully selected patients to either botulinum toxin, sacral nerve stimulation, or intermittent tibial nerve stimulation. And this is not that different from some of the guidelines from Britain, from Europe. Those guidelines are a bit more detailed. So again, first-line therapy are different pharmacologic treatments. The problem with those is they don't work for everybody, as well as there can be some untoward effects for some patients. So if patients don't respond to these sorts of things, again, the things we have are tibial nerve stimulation, sacral neuromodulation, or onobotulinum. So tibial nerve stimulation, the way that this is currently generally done is stimulation is a little needle is placed at the tibial nerve. Patients come in once a week for about 12 weeks for 30-minute session. And if it works, if after 7-8 weeks they find improvement, then they come back once a month, pretty much forever. The problem is this is time and labor intensive, coming back to the office on a weekly basis. Sacral neuromodulation is the other thing, and this I would suggest right off the bat is the outcomes are much better than tibial nerve stimulation, perhaps because it's not just a once a week sort of episode. And I think this has been well researched and well accepted as a appropriate treatment option for refractory OAB. Some of the issues, MRI compatibility. If your patient wants an MRI, at least in the States, it's a very big deal to get one. And again, with the current devices, they've got to come in to have the battery replaced every few years. Now, despite the fact that these have been done now for 21 years worldwide, and I guess you can look at this either glass half full or glass half empty, but worldwide, about 270,000 patients have received an InterStim device. And then the other option is some sort of botulinum toxin. There are multiple types. This is well studied and effective. Still some question perhaps about optimal dosing. And the paradigm for administering it now obviously involves needles with multiple injections into the bladder. So what are some of the new technologies and things that perhaps would ameliorate some of the things that make some of the earlier things that I just talked about a little difficult? So there are different types of neuromodulation, and there's a tremendous amount of work. I mean, there are a lot of different research sites as well as companies working on this. And there are new targets, different nerves that feed in centrally and can actually modulate bladder function. And there are also new devices for some of the nerves we've already been using. There's also some types of radiofrequency ablation and different new ways of administering botulinum toxin, and we'll come to all of these. I think we'll probably end up focusing more on some of the new devices for the nerve targets that we're used to. So if you had to come up with a neuromodulation wish list, I think if we were able to really get to the nerve we wanted more accurately, if we had smaller generators or perhaps rechargeable generators, if we had more programming flexibility, perhaps if we had wireless ones, and if we had things that were MRI compatible, all these would be in the wish list. And then, of course, minimally invasive and cost effective. So these are some of the nerve targets that we can look at. So dorsal genital nerve from left to right, sacral is what we've been using. People have tried pudendal, and we've been using tibial, as I said, for intermittent percutaneous stimulation, but as you'll see as we go along, there's a lot of work in that area. So if we look at the neuromodulation timeline, all the way on the left, so Medtronic had got approval for InterStim in 1997. So again, it's been available for about 21 years. There have been some small modifications made over it. There's been some work in pudendal. There's also been some work in dorsal genital nerve. And then as we move over to the right there, you'll see there's a lot of new interest in both sacral and tibial nerve stimulation. So let's look at some of the new nerve targets. So one is the dorsal genital nerve, and that makes a lot of sense. If you think about it, when the penile or clitoral nerve is being stimulated, the last thing you would want is a bladder contraction. So the dorsal genital nerve has a very significant inhibitory effect on bladder function. That's like when you see little kids kind of squeezing themselves and things like that, that's exactly what they're doing. They're actually inhibiting bladder function. So there was a thought, maybe we can stimulate that nerve. And if you stimulate that nerve, you then get feedback, and ultimately you get bladder inhibition. So this, I listed this as new, but the truth of the matter is this is a study that we did back in 2008. So this is 10 years ago, utilizing dorsal genital nerve stimulation for OAB. And the interesting thing is right after this paper came out and we were getting ready to move on to sort of the more final development, a very large neuromodulation company came and bought this from the company that was working on it, took it, and we've never seen it again. Other people have looked at pudendal nerve stimulation, and there are various ways of doing it. This is actually from an interesting study where they placed S3 leads and pudendal leads, and then they would turn one on, see how the patient did, turn another on, see how the patient did. They had 30 subjects. They sequentially tested the different leads. Overall, 4 to 5 patients actually went on to the full implantation. And the very interesting thing is that 80% found that the pudendal lead, the pudendal stimulation, actually was superior to them, for them, rather than the S3 stimulation. So that's very interesting, and there are a lot of questions and we could have a whole discussion about why that has never taken off, but that's for a different time. Another thing that people have looked at more recently, and this is a paper that just recently came out, is looking at stimulation of the saphenous nerve. And there are various reasons why that may be, in certain instances, perhaps preferred over the tibial nerve. But the bottom line is, it's been done, it's been published, and actually you can see on both of these tables that from baseline to 12 weeks, there are improvements when you stimulate the saphenous nerve. So those are some of the sites that we can stimulate. What about new device characteristics? So this is a new device, and actually my understanding is it was very recently approved in Europe and Great Britain, so it actually is available for use. It is not available in the United States. In the United States, it's actually, the trial just finished enrolling patients, but it'll probably be another 8 months to a year till it's available there. The interesting thing here is the device is actually a lot smaller than the current Medtronic device. Because it has the ceramic end on the right, it's actually very fast charging. And the interesting thing is this is meant to be a rechargeable device. So it should last at least 15 and even maybe 20 years within the patient. So the idea there is that the patient charges this, has a charger that they essentially tape over the device once every 2 weeks. and that charges it up. There's another way you can do it with the belt. But at the end of the day, the idea here would be that you don't have to come back every 5 years to replace the battery. So depending on the cost of this, this could turn out to be a cost-effective device. Here are some of the data, and actually some of these studies were done here, or at least partially here in Great Britain. So this was the very early data, and for a lot of these things, as you'll see, the data is still relatively early. So this was 3-month results, and of the patients who had a positive test, here you can see that leaks per day, voids per day, all those sorts of things improved, and if you look on the right, there were quality of life improvements. This is a more recent study that was recently presented looking at the 1-year outcomes, and really it shows similar outcomes. Bottom line is, it works, and it's a nice new part of our armamentarium when it comes to neuromodulation for the bladder. So some of the advantages for this device: it's quite small, it's rechargeable. Ultimately, it should hopefully be MRI compatible, and it actually, the way that the energy is delivered is a little different from the current Medtronic device, which is voltage dependent. This is current control. So the bottom line is, if you get some scar tissue developing around there, and so that might cause the nerve to get less stimulation, this device will actually change the current so that the ultimate stimulation at the nerve stays the same. This is another company that has a device that's currently being utilized for chronic pain, and now they're sort of switching that over for bladder and bowel treatment. And this again is a rechargeable device. This also has the current-based stimulation. This one is going to be MRI compatible, and this actually has a potential for dual leads. So this is the actual device. You can see it on the right, and there's actually 2 holes there because it's for dual leads. They actually have the potential to have many more channels to stimulate. And you know, right now for pain, they actually have an approval for pain for using 1 lead at a time. So they may put 2 leads in a patient when talking about pain, but they can only really use 1 at a time. Theoretically, this may be something that we can utilize, you know, with more study. You know, I could see perhaps placing 1 lead pudendally, 1 lead sacral, have them go back and forth. I think this opens up a lot of different possibilities. You know, whether bilateral stimulation is any better than unilateral stimulation, I think there's some doubt, but I think that this allows you to have many more tools in your toolbox. The other thing with this is they've actually taken an approach to work on the lead. So the way that they've developed the lead here is it should resist both getting pulled out and getting pushed in, so bidirectional stability. And then finally, they've done a whole thing with the lead itself such that there's all kinds of little braids in it such that it's pretty hard to break. I tried to break one, and I just got some deep red marks on my fingers when I tried to do that. So as you know, sometimes when the current interstim lead is pulled out, it sometimes can break. I'm not sure that has any clinical significance. We can discuss that, but it's nice to have something that hopefully will not break. Then we move into some of the tibial things that people are looking at. So people are looking at either wireless. Most of them are wireless, of course. There are no external connections. They're small. And then the question is there a battery contained in the device, or does it depend on energy coming from a skin source? So some of the principles impacting how much energy the actual lead, if one is implanted, so we're talking now about implantable leads in the tibial area, has to do with how deep the lead is, how much fat there is, et cetera, et cetera. There are a number of different principles that determine how much stimulation will be picked up. So this is an ankle, and up at the foot would be down at the right. And one thing that I want to point out to you is there is a very thick layer of fascia from here to up there that covers the whole area of the tibial nerve and the tibial vessels. So there's the tibial nerve if you follow the line down, and right next to it are the tibial vessels. And that's what actually allows us to locate it, and you'll see it in a moment, to see where the nerve is. So the question is, and here's that cut edge of the flexor retinaculum. It's a very, very dense structure. When you pop through it, you really feel it. And so there are 2 approaches. 1 or 2 companies are making small devices that actually sit external to the fascia, whereas the other ones have implantable devices that are internal to the fascia. So these are some of the, whether it's subfascial or superfascial. So let's look at some of the subfascial ones. This is a company called Blue Wind, and what they have done is they have a very small implantable device that through sort of an open procedure, they actually implant right next to the nerve, and then the patient wears this little sort of ankle bracelet that actually stimulates the device and leads to tibial nerve stimulation. So in their first iteration, this is how they actually do it. They cut the skin, they cut the fascia, they identified the nerve, and then they actually put this in. So they've actually did a study with 36 patients showing nice results. So this was presented at the ICS 2 years ago, and the bottom line is at 6 months, 70% of their patients had a greater than 50% improvement, which is a lot better than the intermittent tibial nerve stimulation. And I think the reason is because here they're wearing these little ankle bracelets, whether it's a few nights a week or every night for half an hour, so they're getting much more stimulation, not just once a week. This also looks at patients who've gotten to 18 months, and again, similar outcomes, and in a few weeks, their 36-month data will be presented. So we should have a lot more information on this device coming up. Now, the interesting thing is this is sort of their next generation. So ideally, what they'd like to do is have one that you don't have to have that whole cut down for. So they're working on an implantable one, and the idea would be there's this little delivery system with ultrasound guidance. You can actually see where the artery and the vein, the tibial artery and vein are, and once you find those, you can actually then locate the nerve. And so in the office, you could percutaneously implant this and leave this very small device behind and really avoid that whole fascial cut down and that sort of thing. And again, with this one, ultimately what you would do is once it was in place, the patient would wear this little ankle bracelet a few times a week for half an hour to stimulate the nerve. This is another one, which is a percutaneous lead placement. And this one is done in sort of going from bottom up. So they find where the nerve is. They actually can use fluoro to help them localize where they're putting the thing. And then the patient wears this thing every night or a few nights a week. So they did a very small study, just comparing intermittent tibial nerve stimulation to the implantable one. And they actually had some good results. So what they showed, and again, this is very small, 3 patients in one group, 4 in another, but the group that had the implantable device, that's the column on the right, had significant improvement out at 6 months. Again, small numbers, but they must be very convinced that it's going to work because their next step, which they just recently announced, is they're actually doing a randomized head-to-head trial of their device against sacral nerve modulation. Here's another one. This is a company that also has a chronic pain device, and this has been repurposed for tibial placement. It's a very small lead, and it's placed percutaneously under complete local, and then they wear a little stimulating patch a few times a week. So this is actually a little video we made, and this is a very short version of it. So essentially, ultrasound guidance, you can find the artery and vein, then you know where the nerve is. You can localize the nerve, and then this is pure local in the office. Make a small incision, you pass a little wire, you'll see it pop through that fascia. Maybe not. And then you stimulate it, you see the foot move, so you know you're in the right spot. And then put an introducer in, get it to the right spot, and then you actually put the lead in, and you test the lead. Make sure you're getting the right responses. And then you just bury the rest of the wire. So there's actually an ongoing study of that one right now. This is one of the ones that's superfascial. So this is a company that has something called the E-coin. And the idea here is that it's right under the skin, but it's above the fascia. And the interesting thing here is the battery is actually contained within the small device. So you don't have to wear anything outside on your, no ankle bracelet or anything like this. So they've actually, and this doesn't have a lead, so it's just this small little round thing that's the size of an American nickel, so it's pretty small. and it just sits there and constantly stimulates the nerve. So they've done a study with just a few months follow-up of 46 patients. They currently have only about 22 patients reporting at 3 months. There were 2 adverse events. One was a pneumonia, unrelated, and then one was a cellulitis, probably because they wrapped the ankle in the wrong way. But again, here you can see actually looking at baseline in the blue and follow-up in magenta, significant improvements. Again, very short studies, and we obviously need a lot more data. So I think tibial nerve seems to be the next frontier. It's pretty easy to get to. You can put a very small lead there. And the question is going to be, is tibial better, same, or worse than sacral? Or is it perhaps chronic stimulation versus intermittent stimulation that's really making the difference? When I tried to get some information from Medtronic, they are very tight-lipped. So the only thing that they would tell me is that they are currently working on a small rechargeable neurostimulator. It's going to be full body safe for MRI, and that they are also working on an implantable tibial nerve device. So the nice thing is, whereas we went about 20 years with really minimal innovation in the neuromodulation space, there's a lot going on now, and hopefully we'll have a lot more to work with, and hopefully they'll have to compete with each other and thus keep costs and charges at a reasonable level. So let's look at some other things that are being looked at for overactive bladder. So one of them is radiofrequency ablation, and there are actually 2 different devices that I'm aware of, and there may be more, but there are 2 that I'm aware of that have been used for this. So one is a company called Amphora, and their thinking is that many of the nerves that actually are related with OAB pass in the suburothelial layer of the trigone, and so their thought was to try to ablate some of these nerves without harming the rest of the bladder. And so this is the device, and they've actually just completed a study that I believe they just presented. And the idea here is that it almost looks like a cystoscope, and what you do is it sort of pulls up some of the mucosa, and then with radiofrequency ablates some of the suburothelial areas in a pattern similar to this. They did 62 patients with OAB. They looked at 2 techniques, either just doing small focal ablations or the deeper continuous ablations that I just showed you. They presented this at the AUA a few months ago with 6 months follow-up. And let's just focus on group B, because that's where the results were better. And what you could see is incontinence episodes were about -3. They dropped by 3. And again, it depends what they started at. We can obviously spend more time on that. But the take-home message is that there actually is improvement, and patients, this is doing something, and this may be something that we will have experience with coming up. There's another company called New Euro that is working with radiofrequency ablation, but on an entirely different thought process. So what their whole device is based on is that there is some evidence that sometimes with OAB, there may be an aberrant electrical impulse that starts within the bladder and then propagates through the bladder, and then either causes abnormal sensation leading someone to have to void, or maybe actually leads to a contraction itself. So these are actually some studies that were done here in Britain looking at, when you have an area of stimulation within a bladder, it actually kind of spreads across the bladder in a wave-like fashion like that, and you can see the pressures change as that's happening. So theoretically, what they're thinking is that perhaps in some patients with OAB, you start from an aberrant area, you get this spread of an impulse, and then ultimately, either because of an abnormal sensation or a contraction, you get that bladder contraction. So what they're doing is they have developed a device that has a radial wire array mounted on a bladder, mounted on a balloon. So it's actually, you put this balloon in the bladder, you fill it up till it essentially fills the bladder, and then these little wires are in contact with the urothelium, and it actually partitions the bladder so that this is what it looks like. And the idea being that when you kind of step on the energy, it separates the bladder into different areas. You can see it over here, so that theoretically, if you now have abnormal impulse starting, it can't move on to the rest of the bladder. And actually, this has been done in cardiac issues and also in some GI types of diseases. And then finally, let's get back to botulinum toxin. So we talked about the fact that we need needles to put it in. So there are a number of different ways of improving the administration that have been looked at, and these are some of them, and we'll quickly go through them. So people have looked at embedding botulinum toxin in liposomes, and what happens is if you just put Botox in the bladder, there are proteases that break it up, and you may not get the effect you really want. And also, how does it get across the urothelium. If it's in these liposomes actually can sort of stick to the urothelium. First of all, they protect the botulinum toxin, and then once it sticks to the urothelium, they facilitate uptake via endocytosis. Avoid needles. So this is actually a study that came out a few years ago, and what they showed is it worked. And so this is an area of active investigation right now. There's another interesting molecule, which is they call it a thermosensitive hydrogel. I've seen it, and it's actually fascinating. So when it's cold, it liquefies, and when you warm it up, it turns into a gel. So its phases are sort of opposite normally. So what they do is they mix botulinum toxin with it, and you keep it on ice, and it just looks like water. And then as soon as you instill it into the bladder and it warms up, it forms a gel that sticks to the lining of the bladder, and that way when someone goes to the bathroom, it actually sticks there for anywhere from 12 to 24 hours, and so there's a lot of time for the botulinum toxin to be absorbed. And actually this is being evaluated for bladder cancer treatments as well. So again, the idea here is that once it's instilled and it warms up and turns into a gel, it sticks to the lining of the bladder and keeps whatever medicine, or in this case, botulinum toxin, there. There's another company using ultrasound. If you apply ultrasound to some of the body tissues at the right frequencies, it can actually cause some of the cells, little channels to open the cells and things to be able to be absorbed. So they're looking at that for instilling Botox in the bladder and then applying ultrasound and allowing the Botox to be absorbed across the urothelium. And people are also looking using low energy shock waves, so almost like ESWL, but very low energy. When you hit the bladder, it causes some of the urothelial, some little channels to open up, and the botulinum toxin is able to get across there. And they've actually done studies in animals, and proof of concept, it looks very interesting. So we'll see what happens once they move to humans. So the bottom line is, there's a lot out there. Current state of OAB treatment, I think we're all very familiar with where we are currently. There are a lot of new technologies, whether it's new targets, new devices, radiofrequency ablation, or ways to get botulinum toxin into the bladder more easily. And I think the ultimate therapy for OAB, if it was a neuromodulation, it would be something that was an in-office implant, effective, you never had to take it out or change it, and you didn't have a big battery that you had to apply. If it's for botulinum toxin, it would be nice to have needle-free administration. And at the end of the day, I think there's a lot of ongoing work right now in this whole area, and I think probably five years from now, what we'll be doing for many of these patients is different from what we're doing right now. This is one of the nicest pictures I've ever seen of Cleveland, so I will leave you with that. Thank you very much.
Fantastic. Open for questions.
Anyone other than Mr. Ockram?
Thank you very much, Suzanne Beers from Cambridge. That's really excellent, very, very interesting. Just talking about methods of getting drugs into the bladder, have you come across the use of electromotive drug administration in the context of some of these things? It may not be appropriate for Botox, because that's quite a complex molecule. But I wonder if that could be incorporated in some of the technologies that you're talking about to enhance the absorption of the drugs even further in the bladder.
Right, so there has been work on that showing success. Whether it would apply for botulinum toxin is another story, so that's why I didn't include it. But there clearly has been work getting other types of molecules across the bladder wall, whether it's chemotherapeutic or some of those sorts of things. So it's another way to skin the cat, so to speak.
And just one other thing, when we're looking at bladder pain syndrome, somebody produced something called the lignocaine pretzel, which is like an intravesical device that had lignocaine on it that had slow release into the bladder. Have you come across any other slow release products? You're talking about the gels, which sounds fascinating, but any other little devices that can be put in?
So there are a whole bunch of little devices. Even going back to when I was a resident, which is a long time ago, we were trying some little balloons that would sort of, you'd put some kind of medicine in it and it would diffuse out over 30 days and things like that. Allergan was working on one for IC. So people are trying it. For whatever reason, none of them have hit prime time yet. But certainly that's an area of active investigation.
Thank you.
Mr. Rock.
Hi, Mr. Joe. Can you use any of these for neurogenic bladders? The Dorsal stable, yeah.
Yeah, so even though it's quote-unquote off-label, we use sacral neuromodulation all the time for patients with neurogenic decreased overactivity. We use tibial nerve stimulation for that, so I don't see why you couldn't. But what I will tell you is currently in all the trials, neurogenics are excluded. So what will probably happen is once these become available, then people will try it and we'll see what happens.
Howard,
Finally, Mr. Ockram.
thank you. Mr. Ockram from London. Can you just comment on the Rosetta study where the improvement levels were good, but the cure rates were poor, and why that might be and how we can change improvement into cure?
So I have a lot of issues with the Rosetta Trial. I think if you look at the long-term data that's come out, you know, it showed botulinum toxin and sacral nerve modulation were actually right at the same, I mean, they had the exact same outcomes. I think if you think about it, they used a much higher level of botulinum toxin, a dose than we currently use for idiopathic. They also used a different lead for sacral neuromodulation, and in order to get in the study, you just had to have done 10 sacral neuromodulation placements, which I would suggest is not adequate to be an expert in sacral neuromodulation. So I think some of it, particularly the sacral neuromodulation aspect, we have learned that we can do a lot better. I remember when I started doing it, or even 8 or 9 years ago, you were happy just to get a response. So, you know, if the lead was going, if the nerve's going this way and the lead was this way and you got a response on 1 or 2 contacts, great. Whereas now we are much technically try to do a much better job to actually get responses on all the leads at much lower power. So I think that we still have the ability to improve our techniques, and hopefully that will improve the outcomes. Can I tell you for sure? I can't, but hopefully that will.
Fantastic. Thank you very much, Howard, for an absolutely excellent presentation.
Brilliant. Thanks very much. Okay, so we've got the pleasure of inviting Professor Frank van der Arm, who's the head of clinic at University Hospital in Leuven, as well as the National MS Centre. His main research is in stem cell applications. Thank you for kindly coming.
Thank you. So my job today is to talk about the current perspectives of female stress urinary incontinence. Let's see how it works, yes. And so before embarking on the current data that we have on stress incontinence, I'm just going to give a short overview of what's actually happening in the world. And if we look at these data, these are data from the American Board of Certified Urologists, and they just checked all their members that are performing stress urinary incontinence surgery from 2003 to 2012. And what you see is that from 2003 onwards, when you give surgery for stress urinary incontinence to a patient, the majority of surgeries is mid-urethral slings, and that what they called the traditional procedures, being needle suspensions, scalpel suspensions, actually went down from a early 17% in 2003 to almost 1 to 2% in 2012, and that there is a baseline of periurethral injections, bulking agents of about 10% or a little bit more that stays constant over the time. This is only urologists. When you look at data from Australia, Medcare in Australia, which are urologists and gynecologists, you can see that the total number of surgeries had a peak at about 2002, and this is the bonus of the mid-urethral slings that came on the market. So all the gynecologists started implanting slings in every patient, even in the urgency incontinent patients, but anyway. And then after a while, they saw that probably that's not necessary, and the number of procedures went down to a more normal level. But again, the same evolution, that the number of what is called here other SUI surgeries is going down, and that actually mid-urethral slings take the bulk of the surgeries for stress urinary incontinence. And I think this has happened everywhere, and certainly also has happened in Belgium. So briefly first, I'm going to rehearse a little bit or repeat a little bit the data that is out there to decide today what we're going to do with our patients. And I think the majority of you will be familiar with this, but just put it in a line again. So first of all, the guidelines, the most easy access, and they state that there's level 1B and level 1A evidence that autologous facial slings are more effective than colpose suspension, that they have a higher risk of complications and certainly voiding dysfunction, and that colpose suspension can have a risk on the long run of creating pelvic organ prolapse, and that probably laparoscopic colpose suspension is equal than open colpose suspension. Now, the majority of these data and these recommendations come from this well-known trial that's out there for now 11 years, but still is the only reason or well-designed trial in the field, I think, at this moment. And they randomized adult women with predominant or isolated stress urinary incontinence between a pubovaginal sling, or a colpose suspension. And at 2 years, there was a significantly better composite outcome, which was quite strongly formulated, so the success rates are quite low, but 47% versus 38%, and this was statistically significant for overall cure, and also for specific stress urinary incontinence. So there seems to be an advantage for the sling procedure. And also treatment satisfaction was significantly better in the sling group versus the colpose suspension group. This comes at a cost of a moderately higher serious adverse event rates of 13% versus 10%, and the main cause of this was the surgery that were needed to deal with voiding dysfunction, actually obstructive slings. And this was spread in about 20 of 326 patients. Now, they have also prolonged the study, and they did a follow-up cohort study on the patients that had surgery in the previously randomized controlled trial. And so about 3 in 4 women agreed to go in a follow-up study. They analyzed this group, and actually this is the group that was more incontinent than the patients that refused to participate. So probably the results in this group are even a little bit worse than they should be on the entire group. And again, with a composite endpoint outcome of stress urinary incontinence, there was still a difference at 5 years between the sling group and the birch group. So we can say that probably on the long run, the benefit and outcome remains there for the sling group. This is satisfaction, and here the same happens. If you compare this to the previous slide, you see that the success rates are actually quite low, but the satisfaction rates actually are quite high. So this shows that probably their endpoint or composite endpoint to define success is quite strong, and a lot of patients are satisfied with the improvement that they were able to get with both the procedures. And so 73 and 83% satisfaction rates on the long run, which is really not bad for a surgery. This was pubovaginal slings. Now, there has been a meta-analysis of Ferdinando Fusco from Napoli that has been published in European Urology, and they actually did a meta-analysis on different treatments. And this is an example of a forest plot where they compared similar studies, so the birch colpose suspension versus the mid-urethral tapes, synthetic slings. And here as well, both open or laparoscopic colpose suspension, if they put everything together, they saw that there was also an overall cure rate that was in favor of the tapes versus the colpose suspension. So in general, I think there's data out there that proves that slings do better than colpose suspension. And this was the conclusion of Fusco and the authors, that there was superiority of the mid-urethral sling for the primary treatment of female stress urinary incontinence, and significantly better than birch colpose suspension. If we're going to play slings, and slings outperform colpose suspension, which kind of slings then should we choose? And in the same meta-analysis, the overall cure rate of autologous slings was not different from synthetic slings, retropubic. So probably they are equally effective. But when you look at the side effects, they saw that the number of patients complaining of storage symptoms was higher in the sling group than in the tape group. So this adverse outcome favors tapes. Now, bear in mind that if you look at these studies, I'm not sure if you can see this because of the projection, but the studies have a magnitude of about 40, 50 to maximum 70 patients in each arm. So they are not really well powered. So there is not a huge amount of data out there to really decide which is the better treatment. And so the conclusion with this data of Fusco and colleagues was that the slings, the synthetic slings, are probably equivalent in efficacy to the pubovaginal slings, both for overall and subjective continence rates, and that they had a statistically significant lower rate of storage slots. And finally, the last part of data, should we, if we perform a synthetic sling because it's got less side effects as compared to pubovaginal slings, should we do transobturator approach or retropubic approach? If you look at, again, the body of evidence that exists, there's only one trial with more than 250 patients in both arms, few trials with more than 100 patients, and the majority of trials is actually quite low in numbers and in power. And you see that the majority of trials does not even reach 50 patients in each arm. So the amount of high quality and well-powered studies out is still low, although we have implanted a lot of slings in patients. And so the only trial with more than 250 inclusions in both arms is the well-known Thomas trial, published as well in the New England Journal of Medicine. And so they randomized TOT versus retropubic approach, and they also had quite strong composite outcome measures for objective, subjective outcomes, and satisfaction with one question: are you satisfied with the outcome of the surgery in a 5-point Likert scale? And actually in this trial there was no big difference, and the conclusion was after 1 year that there was equivalent outcome of retropubic sling versus transobturator sling, and the same holds true for the satisfaction of the patient after these two types of surgeries. The side effects or the adverse events were a little bit different, and this is the most important message. So the profile of the surgeries is different, and I think that most of you know this as well. The retropubic approach obviously will have more voiding dysfunction after 1 year and also immediately after the surgery, and will have more bladder perforation. This is noted as a serious adverse event, which it probably is, but everybody knows that probably on the long run this won't have a lot of side effects or a lot of consequences for the majority of the patients. On the other hand, the transobturator group has more neurological symptoms, and the majority of these were just adverse events, not serious, because there was no extra treatment necessary, and the majority of these symptoms, they reside after a few weeks spontaneously, but there was much more numbness and especially much more weakness in the upper legs after transobturator approach versus the retropubic approach. And again, voiding dysfunction and bleeding were more, or hematomas were more frequent in the retropubic approach versus the transobturator. They also did a long-term follow-up cohort study, and in this specific trial, about 70% agreed to prolong their follow-up. And here, the equivalence of retropubic and transobturator sling was not present anymore. This was an equivalence study, the setup of the Thomas trial. And so this means that the retropubic had 51% success in the composite outcome scores, and a TOT 43. This does not mean statistically that retropubic approach is superior, because this was not the design of the study, but it means that at least we can say they're not equivalent, and probably specifically to the stress urinary incontinence outcome, the retropubic will be a little bit better. But on the other hand, this is not does not correlate with the satisfaction rate, because the satisfaction rate was not different, and in numbers it was even a little bit higher in the transobturator approach. So this is looks maybe a little bit contradictory, and probably one of the explanations is that in the retropubic group, actually again the voiding dysfunction part, they have more urgency, and in this specific trial they also had a little bit more sexual dysfunction, and this results in less quality of life, hence the satisfaction that is not different or even a little bit lower. In the entire group, the quality of life, the sexual function, and the patient global impression of improvement, they do decline over time, but they remain significantly higher versus the baseline. So the treatments both have their effect. And what is also interesting about the long-term follow-up, first of all, in the beginning, probably in the 2000s, we thought that polypropylene, once we put it in, it will last forever and the patients are cured forever. This is not the case. We see also that the effect of these slings go down, and this is something what we learned over the last years. And secondly, between 2 and 5 year follow-up, they saw 1.7% new mesh exposures. So what can we say? This is a small number, but still they occur, and they occur on the long run. So we know that when we implant foreign material, at late follow-up moments, we can still see complications. Nevertheless, we must bear in mind that there are high satisfaction rates of both techniques in these patients, and this is probably a very important finding. Very specifically, if we want to put some kind of a tag on the different techniques, and this is the synthesis of the data that we have, I think we can state, and we can discuss about it later, that Colpo's suspension is less effective to treat stress urinary incontinence. And on the downside of this technique is that we can have wound issues on the short run, and we can also touch the bladder with the technique. And on the long run, it probably results in prolapse in the apical and posterior compartment. And in some studies, it was up to 30%, a figure that was mentioned. The retropubic approach, be it synthetic or autologous, might be more effective to treat stress urinary incontinence as an isolated symptom, but we saw that this not always correlates with satisfaction. In the autologous slings, there can also be some wound issues, hematomas that even require revision. We can have bladder perforations in every retropubic approach. We have more bleeding, and we for sure will have more voiding dysfunction that even will require additional surgery. And also on the long run, we will have persistent voiding dysfunction, urgency complaints, and storage LUTs. The transobturator approach might be a little bit less effective for specific stress urinary incontinence maybe, and there we see vaginal mucosal perforations in the fornices of the vagina, so we have some more issues there, and we can see neurological symptoms. So most of these techniques have quite a high efficiency, but they have a different signature, and this might be interesting to offer to our patients in different settings. What about the mesh story? And what about single incision slings? Very briefly, when we look in the literature, there's a lot of data out there, the majority from, as I told you, quite low number trials, but there is some prospective data from the Thomas trial, 4% at 2 years in the retropubic approach, 2.3% in the TOT group, and after 5 years, 1.7 new cases. So in the end, these figures remain relatively low. A European study, I believe from Poland, they had at 12 months 2% and 2.5%, so also quite low, which is actually quite interesting because they used the IVS tape, of which we know that on the long run it will give more erosion. So this is a proof that early erosion rates might not always be predictive of long-term erosion rate, and we didn't have any follow-up study on this specific group. The meta-analysis shows 1.8, 2.8, erosions, Cochrane 2%. So in the end, all these series have relatively low rates of erosion. But I must admit this is low quality data. An interesting study in this report is the Nielsen Study, who reported 17-year follow-up of the TVT sling. They actually phoned all their patients, and about half of the patients could come to the outpatient clinic, and they had a clinical examination. All these patients were happy and symptom-free. They had no specific complaints. And when they did the clinical examination, they found one asymptomatic erosion. So 1 in 50 is about 2%. Nevertheless, we see these complications. These are all homemade photographs. They come to us and we find mesh. So we should not deny that the problem exists, but we should not make it bigger as it is. And sometimes it can lead to very difficult situations. But it's not exclusively caused by mesh. This is an example of a patient that had a long-lasting urgency after a poor vaginal sling, obviously in another hospital a long time ago. And when we looked into the bladder, you see this kind of stalactite, and this is actually a suture that was passed through the bladder, and that was really epithelialized. So that patient had a missed perforation of the bladder for many, many years. And about this problem, we have no records at all. So actually, this is very badly reported. probably both, but surely the long-term complications of the native tissue repairs as well. So how has the story changed my personal practice? And this is a personal slide that goes for Belgium, for my practice. In reality, for me, not much difference. I think the only change that has been done in our setting is that we give more explicit counseling, and every patient now that gets an implant will have a specific counseling that we are using a polypropylene mesh, that this polypropylene will stay in the body lifelong, and that there is a possibility that even on the long run, it can give some erosions, some extrusions, and so that the figures are relatively low, but that this possibility is there. And probably we also do a little bit more rigorous clinical examination and better registration in the file. But in the end, it didn't really change the practice as how we cope with our patients. Single incision slings, this is a different story a little bit, and this slide shows that we have many models. Some of them are not even on the market anymore. So generally, single incision slings, very important to realize that every sling has its own design, has a specific implantation technique, and has a specific and own learning curve. So you cannot go from one to another because you will have bad results. There's a lot of variability within the different designs. Some perform well, some perform lousy, and they were clearly commercialized too early. That's why we had some bad results, and some flawed models have been used in clinical practice. And by consequence, as everybody knows, a number of these slings have been retracted, some of whom actually had quite good results even. Still, there is a potential in these single incision slings because it has been proven from certain models that they have less pain, and some of them in small trials have proven to have better outcome in sexual function. This is a 3-year follow-up data of a trial where we participated, and it showed non-inferiority of a single incision sling model versus a transobturator approach. So some of these models do last for intermediate term at least. Meta-analyses are difficult because of the element what I just told you. If you have different types with different implant techniques, different outcome, it's very difficult to all put them in one analysis and say that you can or cannot use single incision slings. So it's always very difficult. And so meta-analysis for me are not so informative in this specific area. The guidelines do not advise to use them, really. They say it's uncertain. They might have a shorter operation time, a little bit less pain, but we don't really know what they perform on the long run, and probably this is an honest state as how the knowledge is at this moment. So what are we doing at this moment? When we have a history of stress urinary incontinence, and it's a primary treatment of stress urinary incontinence after failed pelvic floor muscle exercises and failed conservative treatment, we actually do a clinical exam. If there is a positive stress test, if they don't have a residue, we will offer them transobturator sling, and in our specific hospital, they also are invited to go in a register for a single incision sling. If they do have associated symptoms, comorbidities, or even previous pelvic surgery, we will do some more investigations, but in the end, they will probably get the same offer, and they will go for a transobturator sling as a standard of care or a registered single incision sling. This was not really the goal of my talk, but I included these slides anyway. If we have to do repeat surgical stress urinary incontinence treatment, we do the whole lot of examinations, and if they have residual urethral hypermobility, they will probably get a second synthetic sling in our department. If they have very severe incontinence, everything just leaks out, they have a fixed urethra or intrinsic sphincter deficiency, depending on how you want to call it, we will go for probably an obstructive fascia lata sling or even an artificial urinary sphincter in the female. So to conclude, I think the incontinence surgeon should be able to explain the different treatment modalities, and I think even in a center that offers stress urinary incontinence treatment, you should be able to offer also different techniques, at least a synthetic technique and a native tissue technique, and that, that gives your patient the possibility to choose and for you to choose the best technique. What's the future? Actually, there is not really a lot of new things, but some things that are interesting and that are coming up are stem cell applications. For example, you have the Cook myocyte trial that's running, where they take a biopsy of the of the striated muscle in the leg. They send it to the lab, and you get a bulking agent back, some kind of a fluid that you have to inject periuretrally. And it's not clear if it's going to restore the muscle of the sphincter itself or is it going to be an elegant bulking agent. But stem cell applications are on their way. And then obviously smart mesh design. It would be nice to have a mesh with tissue-like compliance so we don't have the extrusion erosion problems. It would be nice to have a mesh coated with growth factors, seeded with stem cells, or a mesh that disintegrates and is replaced by solid host tissue. And there's a lot of research going on also in UK centers to find the best mesh. And I think it's important that we keep on doing a lot of research in this area, and that the door to use certain types of mesh in studies remains open, that we don't close off this field. So to conclude, synthetic mid-urethral sling is still the first-line treatment in real life, and probably rightfully so. Efficacy and safety profiles of the different treatments, they differ. I think you should know them. But actually, although the high-level evidence is limited, we do relatively know well what the figures are. The body of evidence is maybe not in relation to the real-life use, which is gigantic in numbers. And surgeons that treat stress urinary incontinence should be able to offer different techniques and give a complete counseling to the patient. Thank you.
Thank you very much. Can I open the questions, Frank, by asking you, what do you think the role for bulking agents is in stress incontinence?
I didn't include the bulking agents because of time constraints, but bulking agents, for me, have a relatively limited place in the first-line treatment. I think this is more an office-based treatment, which have they don't have a long-lasting effect, in my opinion. Having said this, I must admit I do not use bulking agents because they're not reimbursed in my country and they're too expensive. So,
it is very interesting how reimbursement completely shapes healthcare. Mr. Harding.
We're back on. Chris Harding from Newcastle. So that was an excellent talk, Frank. At the moment, as a section and as urologists with a specialist interest in female urology, we're getting quite a lot of difficulty from patient groups with regards to mesh. You know, we've shown them reviews such as the Sene review, the Scottish report, the English report, all of which look at RCTs, well-conducted trials. We've then shown them real-life data in terms of what happens in the NHS using hospital episode statistics. And they still seem to want more in terms of information. Now, you talked about improving electronic patient records, and that's something we can do, but that kind of data is not going to be mature for 10 or 15 years. What kind of things do you think we can do now to answer a lot of the questions that these patient groups are posing?
I think it's very hard because I think the majority of these patient groups, they want to eliminate every risk. And I think if you're very honest and you look at surgical treatments for no matter what, you will sometimes have a severe complication. And it's hard to find an argument against a case report of a devastated issue. Same holds true for, well, my main argument is that I can also find you a patient after a native tissue repair with very horrible complaints as well. But it's not a scientific answer.
Marcus.
Marcus Drake, Bristol, UK. I'll slightly disagree with you there, Frank, on patients want to eliminate every risk. They're very realistic when it comes to, frankly, looking at the possibility of having an operation. No patient comes along saying, well, I want an operation and it must be risk-free. I think we've actually got a very tangible problem, which is partly that, certainly in the UK, patients seem to have lost trust in their surgeons because the surgeons overclaim their results. For example, emphasizing satisfaction instead of cure. So 80% satisfaction rate that's often what's used, but in fact, the cure rate is 20%. And so if we were really careful, we need to work actually on re-establishing some trust with our patients and making sure that they are realistic and not expecting completely risk-free, but there is a risk, and we've got to be very upfront that there is a risk, and it's an unidentified severity because our follow-ups are actually very poor. So that's not a question.
I agree. Agree. On the other hand, being cured of stress urinary incontinence, by the definition that's used in the randomized controlled trials, is very, how do you call this, heavy formulate, it's very strict. If you take aged mesh control group that does not have stress urinary incontinence, they will also have a success rate of probably 60%, 50%. So I think then we are very strict to ourselves. But I agree that we should maybe be more objective.
So I think this highlights the problem with outcome measures across the various trials. So Paul Hilton did a bit of work which showed that you can demonstrate significant improvement following stress incontinence surgery, and the figures will vary from 85% down to 35%, depending on what measures you make. Now, it doesn't make it very easy if we're all contributing to clinical trials to subsequently meta-analyze if we're all using different outcome measures.
So Philippe Zimmern published in European Focus basically suggesting that we all use the cough stress test. I don't know what people think about that.
What's your answer to the group which says no mesh, no mess? What's your answer? What do you give them? No mesh, no mess. That was a big demonstration outside Downing Street.
To be honest, if I have an individual patient in front of me that doesn't want to have mesh, fine by me. I will give them a fascia lata sling in my hands. We will give them a pure vaginal sling, and I will explain them. I will talk them through the good thing and the bad thing, the complication rates, and so actually we do the same in prostate cancer. They can choose whether they want irradiation or surgery. So this is a patient-doctor decision. I think there's nothing wrong by offering a patient a native tissue sling in first line if you have talked with him or with her, about the risks of using a polypropylene mesh and using a fascia lata sling. I don't see any problem.
I don't think the premise no mesh is correct though, because other procedures you have.
Okay.
If you look at the figures of the sister trial, there have been urethral sections, there have been vesicovaginal fistulae, and even an enterocutaneous fistula after Birch-Colpo suspension in that series, which were all board-certified surgeons.
Okay, I'm going to close the session down. Thanks very much for our guest speakers. A big round of applause for them. The final point is the next session is actually in Hall 1A. It's not here, so that's a joint session with the andrologist. So it's Hall 1A. Thank you very much.